everyone. I am just getting started. So I just want to say that I am home alone with two dogs, and if I close my office door, one of them is going to go wild out there. So I hope that you are in the mood for giving a little bit of grace. We're going to have the door open, and you might hear, who knows, yawning, nails clicking on the ground, any of that kind of stuff. But that's okay. I am just going to give it a minute for a few people to hop on. There's Trishy Trish. Hey, girl. Thanks for hopping on. And if you know me, you know that I am a little bit technologically challenged. And there is an option to share your screen, but whenever you go live, that option goes away. And I did not want to have this be recorded on Zoom because I just feel like it puts another layer in between you and me, and it's another hoop that you have to jump through in order to get on that Zoom. And so I really like for it to live here on my page for a couple of days so that everyone can tune in. If you don't catch it live, you can tune in and get the information, because I know there were a lot of people who actually signed up for this. But it's it's the 4th of July week, and who knows, you might be on vacation. So I definitely want to give you that option to check it out on my page for a couple of days. So with that being said, I am nothing if I'm not resourceful. So what we're going to do is I'm going to share. Let's see, can you see that? Maybe turn that out. Oh, that's worse. Anyway, the only reason that I need to show you these labs, or I want to show you these labs, is because I want to show you what is determined as normal in the traditional world that really isn't normal in the functional world. And yep, there goes my dog. Isn't really normal in the functional world, and something that we would look a little closer at. So if I can't show you these, what I might do is actually put them, let me see here. Let me see if I can put them, and people are messaging me, so bear with me. We're just getting started. If you'll give me just a little bit here so that we can kind of figure out. Okay. Let me see if I can add. All right, hang on one second. All right. I promise this is going to work. if it kills me, it's going to work. Let's see here. Nope. Nothing's going to be easy today. All right, so what I'm going to do is I'm actually going to add these. It's a little bit much for me to add them all as we're going, but let me see if I can do that. No, it's not allowing me to add a picture, but I will. I will add the labs that we're looking at in after the fact so that they will populate in the chat. They'll populate in the comment section, and then you can go back and have a look at what's considered normal in traditional labs and what we're considering abnormal. All right, I hope that's okay. Okay, now I just need to be able to see the labs as well. My gosh, y'all are true friends to bear with me here. Okay, so one of the reasons that I wanted to do this webinar is because traditional labs, our traditional practitioners are busy. And a lot of times they're ordering labs for you as just part of a routine kind of assessment. And when they're looking at those labs, they're actually looking for anything that outlies normal. They aren't really looking whether it's like at the low end of normal or whether it's at the high end of normal, because those might be showing us a trend that if it's towards almost towards low, that might be telling us that that's how you're trending, that you're trending down. If you're almost high, that it might show that you're trending up. The other thing is that traditional medicine and functional medicine have two different ranges of what normal is for almost every lab that we look at. So while there's usually a big range for traditional labs, there is a much more narrow range for functional medicine labs. And one of the reasons is because that range is determined in traditional labs by a bell curve. So if you think anything back to statistics and all that sort of thing, when you have this bell curve, they actually look at where most people lie. That doesn't necessarily mean that it's normal. It just means that it's common. That doesn't mean that it's optimal. That just means that it's common. Like most of the people lie in this region. But when we're talking about optimizing your labs, what we're talking about is to get you in a much more narrow range that actually shows us that we've optimized how your body is functioning, your nutrition, possibly exercise, your body's absorbing nutrients correctly, they're able to use it correctly. So that is why I have had such a huge eye opening now that I've looked at labs that I've looked at for the last 34 years. I'm looking at them in a different way, and it's been very eye opening for me. Okay, so I have a friend who graciously allowed me to use all of their labs. So thank you to that person. And all of this is going to be, no one's going to know who it is. But what we're going to talk about first is, and sorry, I'm kind of back and forth here, is that on this person's, we started looking at a CBC, and that's a common thing that your practitioner would order. It's kind of one of those things that you get every year. I think not normally when it's part of a yearly test are they expecting your white blood cell count to be out of whack. That's usually, they'll usually do a CBC if you have an infection, or you've had some bleeding, or you have tachycardia, or you have shortness of breath, or some dizziness. Because the thing that they're looking at most, they either look at the white blood count or they look at your hemoglobin and hematocrit. So those two things are going to tell us. White blood count is going to tell us, do you have an acute infection or inflammation? That's what they're looking for most commonly. And then your hemoglobin and hematocrit are going to tell us, do you have any active bleeding? Do you have any, are you losing blood in some way, or are you not producing enough of those, enough oxygen carrying cells in your blood? And that's super important also in menstruating women. So if you have any of these symptoms, like you might have, am I recording? It's gonna live on this page, Krista. So if you come to your practitioner and you say, hey, my periods are really heavy, then a CBC is gonna be part of what they do just as a screening tool. Okay, so I wanna talk to you about this person's specific labs, and I'm sorry that I'm not able to share. Like, I can show you, but I don't know if you can see. Can you see that? Somebody let me know if you can actually read that. Again, I will share these screenshots, these pictures in the comments section as we go forward. Yes, you can see those. Okay. So for this person, her traditional labs showed that her hemoglobin and hematocrit were both a little low. This is a postmenopausal woman who is not menstruating any longer. So blood loss because of menstruating wouldn't be an issue for this person. And I just like to explain that what your hemoglobin is actually telling you is that it is the amount of oxygen carrying capacity on your red blood cells. So it is telling me how well you're carrying oxygen from the lungs to the tissues. And if this is low, which it is in our patient, there's a couple of things that you want to look for. Possibly iron deficiency, so maybe their nutrition isn't the best. Folic acid or B12 deficiency. Maybe they're not actually absorbing folic acid or B12. Maybe the form of folic acid or B12 that they're getting isn't the type of form that they can actually absorb. Normally, this wouldn't be picked up on like a lab going forward. This would be something that would be noticed early on in life. So this wouldn't be something that would just pop up in a lab. This would be something that has been shown kind of historically for you. There's a lot of talk out there about the MTHFR gene, and that has to do with folic acid metabolism. And so that's why I'm saying that it would be something that you would kind of know about over a longer period of time. It wouldn't be something that would change because your genes aren't going to change. It could be that you are not absorbing products from the gut. Could be that you have other nutritional deficiencies like vitamin C and that sort of thing. Can all affect your hemoglobin. So things that you want to think about are that you want to increase the protein in your diet. So that would be something that I would talk to this person about, like how much protein are you actually getting in your diet? And there are some people, because of some issues that they have with their gut or some other issues that they might have gotten from a tick bite, where they just don't have a taste for protein. And so it might all be corrected when we actually correct the diet, or when we look a little closer at the diet. Supplementing vitamin C, vitamin B12, vitamin B6, like all of the B vitamins. We usually try to supplement, if we're supplementing B12 and B6, we really should do like a multi-B to help support this. And then the other part of it might be that you don't have enough intestinal fire. And what I mean by that is that the number of people who are actually on proton pump inhibitors because of symptoms of gastroesophageal reflux disease that lower our intestinal fire, that lower our hydrochloric acid in our stomach, that affects the way that we absorb protein, fats, and a lot of the nutrients from the food that we're eating. So if we don't have enough hydrochloric acid, and we are not going to absorb enough of that from our stomach, and that might be something that we need to take a look at. So from this one blood value that's a little bit low, we would look for signs of bleeding. Person's not menstruating, but have they had a colonoscopy? Have they had an endoscopy? Do they have hemorrhoids? Is there any issues with their spleen or their liver? Are they digesting well? Do they have enough gastric acid in order to digest all of those things? All of that from this one lab. And honestly, this lab wasn't even really discussed with the person. They said, yeah, your values are a little low. We're not really worried about it. This person also has a low hematocrit, and hematocrit is the amount of red blood cells in your blood when compared to plasma. So plasma is like the clear serum part of it, and then the red blood cells. So that is what your hematocrit is reading. So when we take whole blood and they spin it down, how much of that is going to be that clear stuff, and how much of that is actually going to be red blood cells? That's your hematocrit. And so all the same things that we just talked about with hemoglobin also pertain to hematocrit. And, we might, in addition to, the vitamin C and the B vitamins that we talked about, making sure that their diet is rich in those, or that we supplement those, or that we have enough hydrochloric acid in the stomach that they can digest those. We might also want to look at iron and make sure that they're not on anything that can prevent them from absorbing iron. Make sure, hey Diane, make sure that there's not something going on that's more sinister, meaning that their body's actually producing enough red blood cells. So we might need to take a look at their bone marrow. We might want to see how the spleen is, if it's collecting a lot of red blood cells because of something that's going on in the spleen. Usually this isn't going to be a consideration when this is just a screening test, because that's when we're looking for something going on, something to explain a change in your blood values. Okay, so let's see, what was the next one? Sorry, I've got a bunch of notes because I want to stay on task. I want to be sure that I am explaining everything to you. Let's see. Okay, so another part of the CBC is not only white blood cells, red blood cells, hemoglobin, hematocrit, platelets. Those are kind of the 5 big ones. But if you have a CBC with differential, it breaks down. It tells us about the size and the structure of the red blood cells and the weight of them, like how dense they are. Plus, it also tells us when we have these white blood cells, what kinds of white blood cells do we have? Because we have multiple different kinds. And so we want to know what's elevated and what's not elevated. Okay, so another thing that this person showed was that their mean corpuscular hemoglobin, or MCH, and if you've ever looked at your CBC, then you've probably seen that and you had no idea what it was measuring. So it's the amount of hemoglobin, which is that oxygen carrying capacity, on a single red blood cell. So essentially, how efficient at carrying oxygen is a single red blood cell for you? Again, this one was low, and it's going to show that maybe you have iron deficiency anemia. Maybe you are B vitamin deficient, and possibly you have intestinal parasites. That was one that came up. Possibly you have an intestinal parasite. And the way that we would test for that is that we would do a stool sample for you to see if that's an issue. But more importantly, remember, functional medicine is a lot of history taking. It's a lot of symptomology. Like, when I do an intake form with a new patient, I have a 16-page intake form history, and it talks about everything. Like it really is talking about all of the history that you've had. What about as a child? And we're getting really specific and really detailed about all the history and all the symptomology that you might be experiencing. But that's something that I have to keep in the back of my mind. This person actually had a history of food poisoning twice in her history, and it could be that she's had these parasites in her gut that have just been doing their thing, leading to her low hemoglobin, low hematocrit, and also to her low MCH. So we did actually order a stool sample for her for a lot of other reasons that we'll bring to light as we continue to talk about these labs. But that's one thing that we have to consider. It's not uncommon, especially, I mean, even in the US, that that we get exposed to parasites. So that's something that, you know, we're both kind of anxiously waiting to hear back from her stool samples. So let's talk about, remember I told you that white blood count gets broken down into the different types of white blood cells. So her actual white blood count was normal. But when we break it down and we look at those individual white blood cells, what it showed is that her lymphocytes were low. And lymphocytes are B cells, T cells, and killer T cells. So these are the ones that actually go through the blood and are like heat-seeking missiles, and they're looking for any tumors, they're looking for any invaders. They actually go out into the tissue and are our first line of defense. So they can actually leave the red blood cell, leave the blood vessel, and go out into the tissues and help to protect us. So her lymphocytes were low, and so what we kind of have to think about that is, does she have a chronic infection? Meaning that maybe her lymphocytes are always out in the tissues and always looking to fight off these this kind of low-grade infection. So when we're talking about that, it's going to be something that's kind of low-grade, so you don't have, you know, you don't feel horrible necessarily, like, you know, you don't have an acute infection, but it's something that your body is fighting off over a long period of time. And when you're doing that, you're using up these cells. So these cells are all out in the tissues and they're not in the blood vessel. And remember, this is a serum test, so we're taking a little snapshot of what's actually in the blood at that moment in time. So a couple of things. So it could be chronic bacterial or viral infection. It could be bone marrow insufficiency. It could also be that we have a lot of oxidative stress in our body, which means that we get oxidative stress from converting glucose into ATP. The byproduct of that is these oxygen-free radicals. And whenever we take an antioxidant, it's these oxygen-free radicals that we're taking that antioxidant for. And so if we are eating more calories or possibly more sugar than what we can burn off in a day, we're going to store that in the cells. And first of all, we're going to ask our mitochondria to convert that glucose into ATP. But we're also going to ask that cell to get rid of that oxidative stress. And so if that system gets overwhelmed, then that's when we can see that the lymphocytes actually increase. And it's our body's response to stress. Might not be an infection, a viral or bacterial infection. It might just be that we are overstressing our cells. And that's why our lymphocytes, they are trying to come to our rescue to help us. And that's why they're actually low in your blood. So we might need to actually support our immune system. We definitely need to look at stress. And we're talking about cellular stress. Certainly mental stress, emotional stress, situational stress is part of that, but we're really talking about how much we're asking our cells to do. And that's the kind of stress that we're talking about as well. All right. Anybody have any questions so far? I know this is a lot of information. This is like, oh my gosh, this is a lot of stuff. Okay. So let me go on. The other parts of our white blood cell, so we can also have basophils, which are the type of cells that get released by the immune system when we have an allergic reaction. And we also have neutrophils, which are the most abundant type of white blood cells that we have. And it's our first defense against bacterial, viral, and fungal infections. So 60 to 70% of your white blood cells should be neutrophils. And these are actually the young, like the baby white blood cells. So they're the ones that are most abundant, and they're the ones that are constantly being regenerated. So this person actually has a high number of that. So what that tells me is that the body is actually trying to fight off something, that it's trying to deal with something. Just as those lymphocytes that were actually out in the tissues, and they were on the prowl looking to protect the body. That's why they were low in the blood. So this is our body's attempt to just throw out all of these white blood cells into the bloodstream, and that's why we're seeing an elevated amount of these. You really have to think about what those cells are doing, and remember that we're looking at a snapshot of what's in the blood. So this is your body just sending out soldiers to help fight whatever's going on, bacterial, viral, or fungal infection. And just based on this patient's history, there's some question as to whether she may be dealing with some mold in the blood, and this was another sign that that's it. Oops, hold on. I don't know what I just did. I just hit something. Okay. So we're looking for leaky gut, because that is one way that our body can be exposed to viruses, fungi, and bacteria. Emotional or physical stress, again, stress on that cell. And then always, it could be an acute infection, but this person doesn't have any signs or symptoms of an acute infection. So what it's telling me is that her body is really working hard to try to fight off something that's going on. The number one thing that I think of when it's just this chronic condition that keeps going on and on is that it's coming from the gut. Because if you think about it, the gut is a tube from our mouth to our exit point. And if we are going to ingest a toxin or a bacteria or a virus or a fungi, if we're gonna get that into our body, it's almost always going to come through our GI tract. And that's also why we have about 90% of our immune system that lies right underneath of that thin layer of our gut. Our immune system is right there because it's at the ready. Because if we're going to get exposed to those virus or fungi, it's almost always going to come from the gut. Okay. The other type of white blood cell that we have is monocytes. And these are the kind that they're actually phagocytes, if you've ever heard of that. So they're like little Pac-Man, and they actually envelop bacteria and viruses, and they eliminate them that way. So they actually chew them up and get rid of them that way. And her monocytes are normal. Okay, so questions about white blood cells, like information that we can tell coming from your CBC, your red blood cells or your white blood cells. Anybody have any questions about what I've talked about so far? And again, a lot of these were actually normal. On her traditional labs, all of these were within a normal range. None of them were outliers other than the hemoglobin and hematocrit. So it just tells you that when you have a more narrow focus, and when we're not just considering what do most people show on their lab values, but we really look at what's optimal, on those lab values, that we can show that there's some outliers and that there are some things going on that wouldn't be picked up by a traditional lab that just has, it's all in the green for this person. Okay, so let's see, what are we going to talk about next? All right, let's talk about a CMP, and that's a complete metabolic panel. So this is going to tell us about the person's diet, about how well they're absorbing things out of the gut, about how, vitamins, minerals, electrolytes, those sorts of things. Okay. So the first thing is that showed up as abnormal. Let me see if I can show you this. Let me see if I can find it. Oh, it's not going to be easy to show you. Okay. That's okay. The next thing that showed up on her functional labs that did not show up on her traditional labs was creatinine. So remember, there's that wider value that's accepted in traditional labs. And what a low creatinine tells me is that, number one, she may not be absorbing protein out of her diet. Or that she has some muscle atrophy. And of course, muscle atrophy is normal as we age after about our third decade. So somewhere about our mid 30s, we start to lose about 10% of our muscle mass for each decade that we age. So for every year beyond 30, about 35, we're losing 1% of our muscle mass. So that's why, whenever I talk to people, especially women, as we age, it's super important that we start doing resistance exercises because we want to maintain that lean muscle. Not only because it protects our bones and our ligaments, but it also helps to stabilize us so that we don't end up falling and breaking a hip, God forbid, or something else. But it also helps to keep our metabolism revved up. And so lean muscle actually burns calories even when you're sleeping. So we want to have as much lean muscle mass as what we possibly can. We want to hang on to what we have, and if we can grow other lean muscle, we definitely want to do that as well. Okay, so her creatinine is low, and creatinine is a byproduct of muscle breakdown that happens during muscle contraction. Hold on one second. No bark. Sorry. So it may be that she doesn't have enough protein in her diet. The other thing that might be happening is that she doesn't have enough intestinal fire in order to absorb. So she doesn't have enough acid in her stomach to absorb that protein, or that she has just accelerated muscle wasting. It could be because she's sedentary. It could be because of advanced age. None of those are the case for this person. So what we've kind of determined based on the history that detailed history that we've gotten is that I'm super suspicious that she does not have enough acid in her stomach, that she's not absorbing some of the things that she needs to be absorbing. Okay, so remember, we're talking about electrolytes, vitamins, some minerals, those kinds of things is what we're looking at now. And one of the things that shows up on the CMP is carbon dioxide. And it's a measure of the acid-base balance in the blood. And it's the way that the body actually maintains that. So it's the way that our body maintains our acid base. I'll leave it at that. So whenever you have a high carbon dioxide, and that's what this patient has, you need to consider why they would be losing losing acid. That's one way to say it. So do they have chronic vomiting? Do they have low potassium? Do they have like a really slow respiratory rate? Do they have, are their adrenal glands not functioning as well as they should be? And adrenal glands are going to give us those what do I want to say? Not neurotransmitters, but hormones that actually help to help our bodies to burn calories, to respond to stress, that sort of thing. So when the carbon dioxide level is high, the biggest thing for this patient is that I'm thinking that she doesn't have enough intestinal acid, and that's why all these other shifts are occurring in the body to make up for that. So it means that the acid in her stomach is low enough that her body is having to compensate by causing more carbon dioxide to be produced or to be retained by the body. The other thing is that it could be that she has some inflammation going on in the body, and that we need to support that through anti-inflammatories. Again, we talked about that she might need some digestive enzymes, because this just keeps coming up in multiple different lab tests. It's showing that she probably doesn't have a lot of stomach acid, and that it's showing up in a lot of these blood tests in different ways. Calcium is low, and if you think about calcium being kind of chalky, you can imagine that you need an adequate amount of intestinal acid or stomach acid in order to be able to absorb the calcium out of the food that you're eating, or supplements, vitamins, that sort of thing. So this person has a low calcium level, which just falls right in line with not having enough acid in the stomach. It could also be because calcium has to be absorbed with fatty foods, that maybe she's not absorbing fat from her diet as well. And then that all falls back to how much gastric acid does she have in play. So total protein is low. Again, that could be that she's not eating a diet that's adequate in protein. But when we looked at what her diet was, it was actually okay. But what she might not be doing is absorbing that protein. Again, it goes back to that gastric acid. She could also have liver dysfunction. She could have, inflammatory bowel disease, leaky gut, things that aren't allowing her to actually absorb that across the intestinal membrane. Malnutrition, bleeding, excessive burns, like there's a whole lot of reasons for this. So what we look at is there a trend? Like, is there something that just keeps showing up again and again and again? And we're seeing inflammation, we're seeing stress, we're seeing low gastric acid, we're seeing possibly a chronic infection or chronic inflammation. So those are all things that I'm looking for in this person's history. Albumin is low. That goes right along with protein. So if you're not going to absorb the protein, then your albumin level is just tells us how well you're absorbing protein in the short period. So it's kind of like, what has your diet been, or what has your gastric acid amount been over a short period of time, like 3 to 4 weeks. And then again, all of this was normal on her traditional lab, so it wasn't anything that got flagged by her traditional practitioner. Alkaline phosphatase was also something that is on the CMP lab, and hers is low. And so what it tells me is whenever your alkaline phosphatase is low, that you consider, does this person have a zinc deficiency? Do they have a low protein diet? Are they not absorbing protein? Do they have low gastric acid? Are there adrenals, which send out those cortisol and stress hormones? Are they functioning normally or not? And whenever your body is stressed out, a lot of times we can fatigue out those adrenals because they're constantly responding to stress in the body. So all of these things just kind of go hand in hand with each other. And we're kind of getting a picture of some of the things that we need to look for, that we need to do some additional functional testing for, and one of the ways that we can test your adrenal function is that we can do something called a Dutch test, which shows not only your sex hormones but also your cortisol levels, and then cortisol levels need to be looked at over a 24-hour period. Just getting a random cortisol level doesn't tell you enough, because cortisol is affected by our circadian rhythms. It also tells us how well your body is metabolizing all of these sex hormones, because there's 3 different pathways that you can metabolize, and one is going to be optimal and the other 2 are going to be abnormal. And so if you're metabolizing your sex hormones in a certain way, it just kind of gets you into a feedback loop, so you can actually be estrogen dominant even in menopause. That was me. So that would be another functional test that we could look at. One other functional test that we might look at is something called organic acids, and that just tells us, again, it talks about metabolism. It tells us about how well your liver and your gallbladder and your adrenals are functioning. So it really starts to look at systems in the body rather than looking just at your kidneys or looking just at your liver or looking just at your heart. We're starting to look at how not only how each one of those organs are functioning, but how do they function in the bigger ecosystem that's going on in the body. So zinc deficiency, you could have liver congestion, you could have chronic stress, you could have chronic inflammation, you could have chronic infection. Okay, let's see. I think we're moving on. Are y'all getting anything from this? Okay. Again, I'm trying to coordinate all of this stuff, so I'm giving you all the good information here. Okay, so let's talk about lipid panel or cholesterol panel. And let me explain a little bit about your cholesterol. So this person's cholesterol was 170, and on this particular lab value, and this has been kind of a recent change, is that we are noticing, or we're realizing, that cholesterol is not burned as fat in the body. It's not the same thing. Cholesterol is that waxy type of lipid. So there's sort of a fatty type of lipid and a waxy type of lipid. That's what cholesterol is. It's that waxy type of lipid. And whenever we are looking at cholesterol levels, what we are looking at is not only cholesterol is less about your diet, honestly, because 60 to 70% of the cholesterol in your body is actually made by your body. It's not really something that you're taking in your diet, although you do get cholesterol in your diet, but the majority of what shows up in your blood is because that's what's produced in your liver. So Just keep that in mind. And cholesterol, there's been all this back and forth about eggs being terrible for you. First of all, you can only have 2 eggs a week, and then you can have, up to 5 eggs a week. And now we're finding that, eggs are really not on the radar if you have high cholesterol. But there are some lab values that will tell you that anything over 150, I'm going to shish kebab a dog here in about 1 second. It used to be anything over 150 as far as cholesterol triggered them to start treating your cholesterol level with a statin. And what we're finding now is that cholesterol is really important in, let's talk about this. It provides the cell membranes with their stiffness and stability. It's a precursor for steroid hormones, and that's going to be like our sex hormones, our stress hormones. It's essential for vitamin D production. Like, how many of us are low in vitamin D? Almost all of us. And it's a precursor for bile salts, and that's what gets produced by the gallbladder, and that's what helps us to absorb fats out of our diet. It acts as an antioxidant. It is needed for normal brain function, normal serotonin function. And then it's also essential for the brain. So our cholesterol levels are actually making sure that they are 180 to 200 versus down to less than 150 is really protective for the brain. So I recently had a church friend that told me she's had a stroke in the past, and she told me she was just asking questions about her lab, and she said that she was on a statin, and her cholesterol level, her total cholesterol level was 120. And I said, that is entirely too low. You need to go back to your practitioner and you need to ask them about that, ask to be taken off the statin, or ask them to do some further testing, because your cholesterol needs to be way higher than that, closer to 200, and that's still a normal value. Okay? So I hope that you hear that. For those of you that are on statins, for those of you that have lower cholesterol levels, just know that 200 is considered normal. And then part of this lipid panel is triglycerides. Triglycerides are, when I see a triglyceride level, this tells me how well your body is tolerating glucose. It's more a marker of glucose metabolism than it is fat. So keep that in mind. So if you're pre-diabetic, or if you have fatty liver disease, what you will notice is that your triglyceride levels will start to go up. A lot of times people have high triglyceride levels, and this really isn't mentioned to them, because that's a hard conversation to have with someone, and it takes a lot of in-depth education, testing, work in order to help someone to reverse that prediabetes, to reverse that fatty liver disease, to help support the body to decrease those triglycerides. Okay, so let me explain a little bit about LDL and HDL cholesterol too. So we hear that LDL cholesterol is our bad cholesterol, when it really, it's okay if you think about it that way, but LDL cholesterol is actually a protein instead of a fat. It's a protein carrier, and what it does is it moves fat from the liver to the cells. And there are multiple different sizes and weights of LDL. So just getting a total LDL number doesn't tell you enough. It doesn't tell you what your risk of cardiovascular disease, including heart attacks and strokes. It doesn't tell you enough just to give you your total level. You need, at a very minimum, you also need to look at what your lipoprotein A is, because that's the really bad one that increases your risk for having bad outcomes and increases your risk of cardiovascular disease, is lipoprotein A. And I would love to hear if anyone's had that done, if that's part of the lab values that you've had done. It really isn't a screening test unless you have a lot of family history for cardiovascular disease. You know, a lot of people in your family having heart attacks and strokes, having diabetes, being obese, those kinds of things, then that is absolutely something that needs to be looked into to determine, are you at an increased risk for this thing to be happening to you? So many times we put too much emphasis on what our genetics are, and what we've learned about our genes is that our genes put us at risk for developing something, but it doesn't mean that it's signed, sealed, and delivered. It doesn't mean that it's a done deal. What it means is that you have a genetic predisposition for this being an issue. But what also gets passed down to us is our diet. You know, how we eat foods, our activity levels. Are we someone who's active, or are we more sedentary? You know, are we eating this standard American diet, the SAD diet? What are our stress levels like? What are our coping skills like? What does our sleep look like? Like, all of those things also get passed down to us. And it's those things, it's those lifestyle things that are going to actually turn that gene on and put us really at risk for developing those diseases. Or are we taking into control? You know, we're dealing with our stress level, we're making sure that we're getting good sleep, we've cleaned up our diet, we're actually getting out there and doing a little bit of cardio exercise, or we're doing some resistance training, and then we can turn off that gene so that gene doesn't really affect our risk for developing those things. So you can't look at it's like environment, you know, or genetics, and they actually go together, because some of the things that we learn and that get passed down to us and that we incorporate as part of who we are those lifestyle things that we learned from our family at a very young age. Okay, so this person's HDL was a little bit low. So let me tell you about HDL. HDL, again, is going to be a protein that carries a lipid through the blood. And the reason that it's considered good cholesterol is that it removes fats from the tissues and brings them to the liver so that it can be processed and acted on by bile salts and eliminated from the body. So think of it as HDL is good because it's actually moving fats and moving cholesterol out of the cells into the liver so that it can get flushed out of the body. And LDLs are considered bad because it's taking cholesterol that was formed in the liver and it's transporting it to the cells where it is getting stored in the cells. Does that make sense? Okay. Things that we would want to see, especially if you have a significant family history of cardiovascular disease, if you yourself have high blood pressure, or you're overweight, if you have high cholesterol, if you're sedentary, if you have metabolic dysfunction, if you have fatty liver disease, all of these things are kind of on a spectrum of sort of the same root cause. And so when you find that root cause and you start working on that root cause, all of these things start getting better. So that's the good news. But one thing that we really want to look at, if you are at increased risk and your lipid panel is out of whack, we also want to look at our homocysteine. And that is, it helps us to determine if you have a B12 and a folate deficiency. And B12 and folate are actually very instrumental in detoxing the body. So is your body able to detox itself? That's really what a homocysteine level is telling us. The other thing that we want to know is about a C-reactive protein, and that just tells us that you have inflammation going on, and that the cholesterol and the lipids in your blood are a little bit sticky, which means that increases your risk for developing a heart attack, a stroke, having these plaques form in your body. And whenever I see that we have the C-reactive protein that's high, not only do we need to look at stress, but we also need to look at inflammation. And when we are talking about inflammation, you have to look at the gut, because it usually means that you have a leaky gut, and things that are meant to just stay in our GI system and get eliminated from the body are actually going across this leaky membrane that we have in our gut and are entering the bloodstream and are getting our inflammatory and our immune response revved up, and that is causing inflammation throughout the body. So C-reactive protein is really important, especially if you have all of that family history, or if you yourself have had a stroke in the past, or if you've had a TIA, or if you're going in the wrong direction and you're starting to develop, your triglyceride levels are going up, your insulin levels are going up, your glucose levels, your hemoglobin A1C is starting to go up, your weight's starting to go up, the size of your waist, like, are you starting to hang on to that weight all around the middle? Those are all reasons that we would want to see a C-reactive protein. This person they are experiencing some of that, and a C-reactive protein was not done. So her HDL being a little bit low, that's something that we can affect with diet and exercise. And other than that, all of her values were essentially normal. Okay, so let's talk about blood sugar. And this is the last thing. We're almost done. You guys are doing great hanging in here. I didn't mean for it to go this long, but hopefully you're getting some good value out of this. So this person's fasting glucose is a little high. It was 110. And her hemoglobin A1C was a little high at 5.5. So that's just a little bit high. And her primary care doctor didn't say a word to her about her hemoglobin A1C, did not say anything to her, or mention in passing that her fasting glucose was a little high. So you ultimately want your fasting glucose to be less than 100, and you want your hemoglobin A1C to be less than 5.3. And when we looked at her value, you can kind of extrapolate. So hemoglobin A1C is kind of like a diary of what your blood sugars have been over the last 3 to 4 months. So it really kind of gives us some historical data, and you're not going to get away with saying, well, I had eaten a big dessert the night before. Even though I was fasting, I'd really eaten a big dessert the night before. This hemoglobin A1C is going to tell on you, because it's going to tell us what your average glucose levels have been over the last, like I said, 90 to 120 days. So when we correlate this, the fasting glucose that she had of 110 and her hemoglobin A1C of 5.5, actually 5.5 tells us that your average glucose over the last 3 to 4 months has been 111. So that's very consistent. And not only is your hemoglobin A1C going to pick up on what your average glucose, what your average blood glucose is, but it also picks up those times when we spike our blood glucose, and that can be from eating a high carbohydrate load from eating our standard American diet, from having, chips and cereals and processed foods and, those kinds of things that spike our blood glucose. So it might be that we have, that our blood glucose isn't balanced, where we have high spikes and then it's followed by a dip in our blood glucose and then a high level again and a dip in our blood glucose. That could also, we could estimate or guess that part of your hemoglobin A1C being high is coming from those glucose spikes. If you are someone who eats every 45 to 90 minutes, if you are someone who gets hangry, like you just have to eat right now, and when you are and you have food cravings, especially at night, if you're craving carbs, if you're looking for those sugary or crunchy things to snack on, if you're snacking all throughout the day, those are all things that would make me suspicious that you have a blood sugar balancing issue. And that's something that we can look at more in depth with a food journal. We can give you some dietary suggestions. Intermittent fasting might be something that would work for you, cutting out sugar, having you to increase the amount of fats and proteins that you have at each meal. All of those things are things that we would talk about as ways to help to stabilize your blood sugar, so that if you're not having those high spikes and then those followed by those low lows and that high spike again. Other things that I would like to see. Oh, so this person, I gave her, when we knew that she was getting labs, I asked for some functional labs that aren't traditionally done, blood labs that aren't traditionally done, because anytime that I can have someone's insurance pay for labs, I absolutely want to take advantage of that. And her traditional practitioner was very willing to accommodate as much as she could. And so one of the things that she did was told us about what her insulin level is. So when your body is exposed to glucose over a long period of time, increased glucose, then it starts to, so let me back up. Our blood glucose is meant to stay within a certain range. And the reason that it's meant to stay within a certain range is because too much glucose in the blood at any one time is a toxin to the brain. Okay, it's a toxin to the brain. So that's why when we are, our bodies are so wonderfully made, and we're going to increase our insulin in order to keep that blood glucose low. So over time, when we first start out, insulin is released in order to shuttle that glucose that's in the blood into the cells, because what we're really looking at is just what's in the blood because of how toxic it is to the brain. So over time, if we are eating more calories and more sugar and more carbohydrates than what our body can accommodate, that you wouldn't think that it's very adaptive when we are storing those extra that extra sugar and those extra carbohydrates as fat in the tissues and in the liver, even to the point of fatty liver disease. But the reason that we're doing that is because we need to maintain that very narrow window of what our blood sugar is, because it's toxic to the brain. So our body is continually releasing insulin, and over time, it's going to release more and more and more insulin in order to maintain that narrow range. So whereas, the first year, it might be that your insulin levels are normal, but in the second or third year, as your hemoglobin A1C is climbing up a little bit, now what we notice is that your insulin levels, it's taking 2 or 3 times, sometimes 4 times as much insulin to keep that blood glucose normal. So we asked to have a fasting insulin level done, and hers is actually normal. So it tells me that we're going to be able to take control of this, and we're actually going to have a good result by balancing her blood sugars, by making sure that she isn't having those insulin spikes, and by making sure that we're influencing what she's eating, and we're sort of steering her away from that standard American diet that has a lot of processed foods, a lot of carbohydrates, and we're actually increasing the number of fats and the number of proteins that she's getting at every meal, and then the number that she's getting is going to be increased all throughout, in a total day. The other thing that we're looking for is a C-peptide marker, and we didn't get this, but it actually tells us it's a polypeptide, which means like kind of a pre-protein that is produced by the beta cells of the pancreas along with insulin. So as insulin levels go up, this level is also going to go up. And then the other thing that we would look for in functional sugar testing or glucose testing, we would look at an adiponectin level. And adiponectin actually is a measure of the hormone produced by the fat cells that is protective against producing cardiovascular disease. So are your adiponectin levels high enough or not? It tells us, does your body have some protective mechanism that we can balance out what your cholesterol levels are, to really take a really good look at what your cardiovascular risk is, not just looking at cholesterol. Do you have something going on in your body that's actually protecting you? Of course, we did not get an adiponectin level. And then leptin levels. So just like we get insulin resistant, we can also get leptin resistant. And our leptin is a hormone that helps to regulate our body weight by controlling our appetite and our energy level. So just as our bodies can be resistant to insulin as we're producing more and more insulin to keep that blood sugar in tight control, the leptin levels, the leptin also goes up, and those cells just get sick of seeing insulin, get sick of seeing that leptin as it's trying to, bring our appetite back into control. It's released by fat cells. So when our fat cells start to get full, that's when we're releasing more and more leptin. But again, if our cells aren't responsive to that, if our cells are kind of sick of seeing insulin and sick of seeing leptin, then that effect is essentially gone. Okay, I'm gonna leave thyroid. We may have to do another one because this is already an hour long and I don't want to lose anybody. But what I might do is just pop on here and just give you a quick little look at the thyroid labs that I have, because they're actually very interesting, and I want to take a moment to explain it in detail, but I don't want to wear you all out in one webinar. So if you found some value in this, add people to this page. Share this video with them. Well, actually it's on my business page. I don't know if you can, I think you can share it. Or invite people to the page so that they can take a listen to it. And if you saw yourself in any of these labs, like if you saw this scenario, some of the things that I talked about, if this looks like your labs and you know that there's something going on with you, but it really hasn't been explained fully by the traditional labs that you're getting done, or your traditional practitioner isn't explaining some ways that you can improve, and get the trend going in the right direction of where your labs are headed. I am always taking new patients, and this is what I love to do. We look at different labs. We look beyond these blood labs, because many times it requires us to look at we need to look at the end result of metabolism, the end result of methylation, the end result of detox, so that we can look at the whole entire ecosystem of the body and tell whether you're in a good place or whether we need to support your body to do what it does naturally. Okay, guys, thank you so much for tuning in. I hope that you got something from this. If you have questions, feel free. I will be checking back here and answering those questions as best I can. Thank you so much.